So I'm gonna do this a little bit differently. I'm actually got a mic on me because I like to move around a little bit. I don't like to stay in one place necessarily. So I'm a nurse practitioner in Edmonton, Alberta. I've been doing this now for like 20 some years, looking after patients with CLL, and I consider you guys my work family. And so it's my joy to be here today. I really want to thank the CLL Canada board for inviting me, and I want to give them like ultimate kudos for the great job that they've done in bringing together a great bunch of speakers over the last 2 days. I've sat in on all the sessions and got to hear what was presented and see your responses and participate in the outbreak group for the treated patients, and it's just been a real joy to see how engaged you guys are. So you've had some pretty fancy lectures today and yesterday talking about immunity and secondary cancers, and I want to kind of simplify all of that. And so I want to apologize in advance if for some of you this feels a little bit too basic, but there's some people who need to hear a story, and you become more engaged when you hear about this as a story instead of just technical science. And so I'm going to do that with you. I'm going to talk about the steps to immunity and what we may be able to do to help protect ourselves from illness, and then talk about those secondary cancers, what ones. We've talked a lot about them, but which ones particular, and then talk about what the surveillance recommendations for you so that you can take that back to your providers. And then I'm going to acknowledge the anxiety that comes along with all of this and suggest some mitigation strategies. There's no evidence about what to do. It's just me just talking about what I do. So I want to talk about Bob. CLL is a B lymphocyte malignancy, and so Bob is a bit of a cowboy. He's out there constantly looking for a fight. He's got his arm out and he's constantly looking for viruses and bacteria and parasites. And when he comes across something, he's looking for a fight. He's got his arms out, and this is my IGHV heavy chain. And so he's got this out here and he's looking for a fight. He's very aggressive. Bumps into people all the time. Hey, you seen anybody that I can take on? And he's like, and they're like, no, not nobody here, man. Goes into the next lymph node. Hey, anybody seen anybody I can take on? Well, you know, there might have been some, I think, chicken pox down over that way. And so Bob would go and engage with the chicken pox, and he'd pick up a little sip of it, take a look at it and go, I don't know how to fight all of that. And so he goes running to his friend, a T cell. There are lots of different T cells. This is Tom. So there's lots of different T cells. You've heard a lot in the lectures about natural killer T cells, T cells that can go off and fight things all by themselves. But there are some T cells, helper cells and regulatory cells, that actually help Bob to do his job. So Bob goes up to him and says, hey, I found this. I don't know what to do. And the T cell says, that's okay. And he sprinkles him with pixie dust, and Bob is transformed, and his little gun, this cowboy, he's transformed, and he can now shoot antibodies. Pew, 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 pew. Anti-chickenpox, anti-chickenpox, anti-chickenpox. When he's done fighting, he rides off into the sunset as a memory B cell, and he will be forever immune to chickenpox. Some Bobs will go off to die, and some Bobs will go on to be this memory B cell. So it's this whole business of these guys talking to each other that is impaired when you have CLL. So first off, there might be a whole lot of Bobs that are shooting blanks. There's a whole lot of Bobs that never get transformed because they're unable to. There's a whole lot of Bobs that are constantly bumping into Tom and bugging him, and Tom becomes exhausted. We heard about that. He becomes exhausted listening to him and stops listening. So this whole paradigm of searching for things, picking up that virus, bacteria, whatever, internalizing it, and then running over is where our problem is. Bob has cancer. When this immune globulin heavy chain is out, this is unmutated. He's looking for a fight, so he's more aggressive. When he's internalized, he's now mutated, and he's now chicken. So that's why it's a little bit easier. He's a less aggressive cell, because he's a chicken. So if I have too many bobs, why am I immune compromised? So these guys are functionally incompetent. As I said, they're shooting blanks. They're all in the basement watching Star Wars, and they're not responding to the battle that's happening on the main floor. So mom and dad are upstairs going, would you please come up here? And they don't come, and when they do come, they're like this, like a lazy teenager. They're slower, and so people with CLL may be sicker more often and sicker longer than their counterparts. So if in my household somebody gets sick, I'm gonna be sick for 7 days and they were only sick for 4 days. There's less antibody being produced because of the BOBS dysfunction, so there's less immune globulin. Immune globulin is another name for antibodies. There are three types of immune globulin I want to talk about. The first is IgA. IgA likes to hang out around the nose and the mucous membranes. And we have less IgA when we have CLL over time. And that's why we end up with more infections, because the IgA is now not functioning to keep germs from passing through our nose and our mouth. So more sinus, more pulmonary infections. IgM, I call it the morning antibody. It's the one that first gets up and starts the fight in the battle. And there's usually not so bad IgM levels, but IgG is the gone for good one. This is the one that's gonna get rid of that thing forever and help you to be immune for life. And when we're having less BOBs transforming to produce IgG, the IgG levels go down over time, which contributes to our immunity problem. So how can I quantify my risk for infection? So we're going to talk about disease burden, immune deficiency, treatment effects, and environmental awareness. So in terms of disease burden, I like to think of the bone marrow as a giant cul-de-sac. There is my house that has the hemoglobin house, the red guys, red blood cells. There's my platelet house. These are the guys that help me to clot. And in the center, there's my BOB house. There's my lymphocyte house. And there's too many BOBs. They're having a party. We know because we peeked in and we saw that there were too many lymphocytes, which is how we got our diagnosis of CLL. And as long as everybody is still functioning, you can see the driveway into the cul-de-sac is clear. Everybody can get out and do their job. That means there's going to be normal levels of hemoglobin, normal levels of platelets, normal levels of other white blood cells. Then all is good. But as soon as BOB begins to overproliferate and block the cul-de-sac, people can't get out, and our numbers start to go out. So our hemoglobin numbers drop, our platelet numbers drop, and this tells us that we now have a higher disease burden. So if you're early in the process and your hemoglobin and platelets are not so bad, then your disease burden may be low. And the only way to really check that is if we went in and did a bone marrow biopsy and actually looked at all the cul-de-sac. But that's an invasive procedure, and so it's easier just to monitor by doing peripheral blood work. In terms of immune deficiency, your spleen is a part of your lymph node system. So Bob is born in the cul-de-sac, he pops out, he checks in where? At all the lymph nodes. Anybody seen anybody for me to attack? Then he moves on to the next lymph node and the next lymph node, and then he pops back into the marrow, double checks with everybody what's going on there. And when he gets stuck in the lymph node, he can then proliferate there. And so that's why the more white cells we see in circulation, often the bigger the lymph nodes are getting, and then they're stuck there and getting bigger and bigger and bigger over time. So when our spleen is part of our lymph node system, that means that BOBs are gonna get stuck in there. And the spleen normally, I like to call it, in the Star Wars analogy again, Yoda. So all of our white blood cells are born as Jedi Knights, but just like Luke Skywalker, some of them need extra training to be able to fight the dark force. And that happens in the thymus gland in the spleen. And so if our spleen isn't functioning normally or is super enlarged, it may not be able to help with the Yoda training. And so we have a higher risk for infection from encapsulated organisms. What does that mean? It's a particular type of germ or bug or bacteria, parasite that has a level of carbohydrate on the outside, and that gives it extra protection. It makes it harder to fight. And so Yoda used to train these guys on how to get rid of them, and now Yoda's not functioning so well. And so we have a higher risk of infection from things like Haemophilus influenza, meningitis, strep pneumonia. And you notice that there's a couple of those that you can actually get vaccination for. Another way to quantify our immune risk is actually measuring the IgG levels. But does that tell us everything we need to know about our level of infection? So if the ones in the blue are a group of patients that were, this is like 4,500 patients, they all were identified to have low immune globulins. So that was the secondary immune deficiency. Why is it secondary? It's secondary to CLL. So it's an immune deficiency caused by something else. So the blue guys, you can see high risks for infection, but even in the guys who had normal IgG levels, which is the orangey red guys, you can see they still had risks for any infection and severe infection. So even if your IgG levels are normal in CLL, you still have a risk for infection. The multiple causes for the infection include bacteria, viral, fungal, and parasitic. I want to just pause here for 1 second and say, I'm sure some of you are aware that this is being videotaped, and this will be available on your CLL Canada website later. The upper left-hand corner of any slide that I have data on is a QR code, and if you scan that with your phone, it will take you directly to the article I've cited. When your IgG levels are normal, and you're still having lots of infections, I want you to flag that to your provider, because there is an extra special test that may be able to be done. It will depend on your center. The blood may need to be sent out. You may need to be referred to an immunologist, but IgG is actually a measure of a group of IgGs. There's IgG 1, 2, 3, and 4. And it's like a domino. 1 tells 2, tells 3, tells 4. So if you're missing 1, 2, 3, and 4 will not function so well. If you're missing 2, 3, and 4 won't function so well. And so this subclass test can sometimes flag that the total number of immune globulin is fine, but we're missing a particular subclass, which is contributing to your higher risk for infection, especially if it's sinopulmonary infections. The reason why this is important is because if you have low immune globulin, you actually may qualify for IgG replacement. So this can be, this is a blood product. When you donate a pint of blood, not you guys with CLL because you can't, but when your family members who you're going to encourage to donate a pint of blood, that pint includes their immunity. And we can actually filter out the immune globulin and pile a bunch of people's immune globulin together and give it to you. Those antibodies are proteins that live for up to 30 days. And so you would then benefit from somebody else's immunity for a whole month. So we can give that intravenously, which would have to be a hospital-based therapy. It's going to take time, 4 hours about. You may have to travel to that hospital, which I don't know where you live, but it may be close and it may not be. And then it's going to need to be given every month. And there are some physicians or some care providers who will have patients who have super low IgG levels who will give them a top-up of immune globulin during the high-risk time, like the flu season, and others who are at risk all the time, and so because they have other underlying health conditions like COPD, lung disease, and so they're getting it all the time. And then there is the ability to actually take that product and instead of giving it in a vein, to give it underneath the skin. So we call that subcutaneous. And we can teach you how to do that. And you would do that at a minimum once a week, smaller doses. And instead of having your intravenous therapy that shoots your level up and then it gradually dies out over 30 days, you would have a little boop and a little bump and a little bump so that you stay at a nice level and don't have the big wide swings. So there's less side effects with the subcutaneous route. It's self-administered, which some people find better in terms of flexibility. There's a cost saving to the health system because you're not having to go in and take up a chair and be seen by a nurse. And there's less infusion time, but it is your infusion time, not a healthcare infusion time. There's studies that show that there's improved quality of life when you're on the subcutaneous. And then there's that improved stability of the immune globulin level instead of these wide swings. It's important to know that while I'm encouraging you to have this, it won't necessarily, I said you may benefit or may qualify for immune globulin therapy because there are rigid guidelines throughout all the provinces that are not the same. So within Alberta and Ontario, you have to have 2 IgG tests that are lower than the limit of normal on 2 separate occasions. And they never recommend this for just primary prevention. So you've got a low level, but you're not having infections, we're not going to do it. This has to be that you've had an invasive, life-threatening infection in the last year or recurrent severe infections. So if you're having those recurrent infections, you want to explore this with your healthcare provider to see whether or not this is something that's available in your area. And is it available intravenously or subcutaneously? Because that also may be different depending upon the expertise of your provider in terms of are you seeing a family doctor, or are you actually seeing a hematologist, et cetera? Or do you need to be sent to an immunologist to get this done? So in terms of our immunity, there also can be treatment effects. And I'm just gonna flag that was discussed by Dr. Spencer Gibson yesterday when he talked about how there's been immune reconstitution seen with certain types of therapy, in particular, things like ibrutinib. And there is other treatments that will further impair your immunity. So Bob, you remember in the very beginning lecture, one of the physicians talked about something called flow cytometry, and it was where you were testing to see how many B cells there were. What you're looking for is basically what I call Bob's jewelry. So Bob has a label on his hat called CD19. He has an earring called CD20. He's also got another earring called CD5. On his belt, he's got CD23. And so when you think about targets for therapy, these may be targets. What if I could have a heat-seeking missile to find CD20, which is a monoclonal antibody? So it seeks out Bob's earring, blows him up. So if you've had a CD20, rituximab or obinutuzumab in the last 6 months, you're going to have a significantly less B cell population, even your healthy B cells, because CD20 is found on healthy B cells as well. And no immunization after 6 months is going to be very effective because there isn't any Bobs to respond to that vaccination. I want to just mention that there also was some discussion about CAR T cells and that that's a treatment of the future that we're hoping to get better. And right now it's this effective, whereas other treatments are this effective. But we hope that that will get better over time. But CAR T cells do also come with toxicities. And one of those toxicities is that their target right now is on Bob's hat, the CD19 label. Every single guy that has CD19, healthy or cancerous, is going to be targeted and wiped out. And so in the lymphoma trials around CAR T cell therapy, up to 60% of people are on long-term immune globulin replacement therapy because there are no Bobs. So your immunity won't necessarily get better after CAR T cell therapy, and in fact could be a little bit worse. So it's not the be all and end all of making things better. So what can you do in terms of some practical things? Those are some things that you should be aware of, and that you can ask about. But when you're yourself deciding about how do you want to live your life and walk functionally, being immune compromised. So I also am immune compromised. I don't have a functioning spleen. So it got removed. So I practice all of these things. I don't touch handrails. I don't press or use doorknobs. I don't press elevator buttons except with my elbow. I carry hand sanitizer in my pocket. I wear a mask when I'm on a crowded plane. I take I'm very aware of when I'm in crowds and if someone's coughing and sneezing or hacking. I'm very aware if I'm going to attend an event where there is singing. So we actually learned that during COVID, there was, you'll see in the link there was a case control of karaoke-related coronavirus. So they're actually able to tell that a whole karaoke place in Japan became infected with the same strain of COVID because of singing. And so we also found that also in church environments. And so if I'm made a mistake, went to an ABBA cover band thing, totally didn't think the crowd is going to sing along. And so I ended up getting sick because the persons around me were all singing along and I hadn't brought my mask, and now I would think twice about that. If you're going to be in close proximity to unwell persons, being aware of that risk. But then I also have shared with everyone in my personal life, I am immune compromised. I would rather that you canceled on our dinner plans at the last minute than you show up coughing, hacking, and wheezing. If your kid is suddenly got a runny nose and they're gonna come over to my place, I would rather you canceled. I don't care if I've made a beautiful turkey dinner. It's more important for me to not get sick and to not bring it to my work family than for you to come to dinner. And I'll tell you that since I've shared that with my friends and family, I get sick less because they're more respectful of not bringing germs into my environment. You also can be aware of the risk out there in the community by doing some quick surveys if you're going to travel somewhere or you're going to come to Niagara Falls maybe. So when I pulled this lecture together, it was February 23rd, and I went to this website. I literally Googled Canada wastewater influenza, and it popped up with this website, Health Infobase Canada, and you can actually look at this to find out in the area that you're going to, what is the COVID-19 level, what is the level of RSV, and what is the level of influenza. So they're tracking in the sewage levels of copies of the bacteria and viruses, and so you can actually see by little high dots, moderate dots, low dots. So this I think I did for Toronto area because I figured there might be a lot of people here from Toronto. And in February, you can see the little dots and risks around there in terms of whether the risks were high, low, or low. For Toronto Highland Creek, we had a super high level of COVID-19, but that same area had a moderate level of RSV. There are, in my province in Alberta, sorry, I keep touching the microphone. In my province in Alberta, we track the wastewater, and I can actually track it within Edmonton, Red Deer, et cetera, for influenza A, B, RSV, and COVID. And so I wasn't able to check for individual provinces. I was only able to find for this one sort of global Canadian website. So one of the panel discussions earlier today was about when you're sick, when to take action, and who should you call. And so this also needs to be a discussion between you and your health provider. Are you calling Nan, your nurse practitioner, or Dr. Barisha Banerjee, your hematologist, or are you calling your family doctor when you're unwell? And as was mentioned, every provider will have their own sort of mechanism of handling those kinds of things. Personally, I've asked the family doctor who's living closer with you and who's going to see you more often, because especially if you're in early stages of the disease, I'm only seeing you maybe once or twice a year. I want you to see your family doctor when you're unwell. And in particular, I want to flag that if you've been sick for 5 days and you're only getting worse and not better, this is a phone call. If you've been sick for 5 days and you're getting better, then you're probably going to be fine. If you're sick for 5 days and then suddenly you get worse, better and then worse, you've probably developed a super infection, something you had a virus before, and now maybe you have a pneumonia on top. So this is a phone call. You want to explore whether there's any opportunity during those seasons to be tested for flu or COVID. So there are, according to Amazon, some kits that you could buy to test for COVID and flu in your own home. In my local pharmacy, I was able to get a COVID test for this last year so that I could do that at home. And why is it important? It's because there is early intervention if you catch this in the first few days. Whereas if you wait until you're super, super, super symptomatic and super, super sick, you might be outside that window. So we want to get in there and get there early and prevent you from being hospitalized. So if you know you're immune compromised and you've taken the test, you're positive, you're calling your oncologist or your hematologist to say, hey, is there an opportunity for me to get preventative therapy to make sure this doesn't get out of control? So let's talk a little bit about vaccinations. This has gone over, we've talked about it before. Yes, an annual COVID shot or whatever COVID shot's being available in your province is recommended. An annual flu shot. Remember, these antibodies have lifespans. So after you've been vaccinated with flu, those antibodies are going to be around for about 6 months. That's why we redo it every year. Pneumo 20 is a pneumococcal vaccine. Remember, we talked at the beginning about those encapsulated bacteria. So pneumococcal vaccine is recommended, and it's now a one and done, a Pneumo 20. It used to be 2 different vaccines, but now it's Pneumo 20, which is pretty much one and done. There's a new vaccine called RSV. RSV used to be really common in kids. It was the most common cause for kids to be admitted in hospital, especially under the age of 2. And then since COVID, RSV has become more common in adults, and particularly those who are immune compromised and over the age of 65. So there's a vaccine that's now available for those persons over the age of 60, but it may or may not be funded. In my province, it's only available to persons over the age of 75. I can prescribe it for anyone over the age of 60, but they'll have to pay about $300 to get that vaccine. Shingrix, you're more at risk for reactivated shingles. And so Shingrix is a non-live vaccine that will help protect you. So in the clinical trial for Shingrix, there was a portion of those patients who were immune compromised, and it's a little less effective at preventing you from having shingles, but it was very effective at preventing the neuropathic pain, which is nerve pain that can come with shingles, especially the long-term nerve pain. And if you've ever known anybody who's had that, it's worth the cost to get shingles. It's not typically covered unless you have a fancy drug plan, but it's 2 shots administered 60 days apart, and the total cost should be about $300 at the most. If it's more than that, go to Costco. They're cheaper. We've talked earlier in the conference about live vaccines and how they're generally recommended, not recommended. If you go to any website that talks about clinical guidelines around vaccination, it will say that persons with CLL are not recommended to have live vaccines. And that does put your healthcare provider kind of in a pickle when there's all these guidelines saying that generally live vaccines are not recommended. And then so our general advice then becomes it's patient specific. So why is it patient specific? Remember when we talked about the cul-de-sac and the marrow burden? If you only have 1 bob in-house, maybe the burden is less. And so maybe it might be a safe thing to consider, and we can talk about the risks to you. And it's an individual decision where you've consented and you've heard the risk. But if you have lots of bobs, or you're on treatment, or you've had a CD20, and so we've blown up all the healthy bobs, then this would be a much higher risk vaccine for you and not recommended. We also talked about blood testing. Can I actually see, do I have IgG measles? Yes, you can. However, the most common blood test for IgG measles is yes, there are some, no, there isn't. It doesn't tell me how much. The yes is the minimum threshold that's been determined by some, fancy people. Is it the maximum threshold needed for an immune compromised person? We don't know that. We just know that you got a yes. So that it's going to tell you that you have some immunity in terms of the IgG measles. But remember, if it's there and even a little bit positive, that tells me that Tom saw this and Tom remembers. Tom also has the ability to activate everybody else. And we know this because even though during COVID there was quite a few clinical trials that looked at the measurement of immunity that you got from COVID vaccination. And there was a whole group of CLL patients that had no measurable antibodies to COVID after vaccination, especially when they were on drugs like ibrutinib. But we didn't see this huge hospitalization rate. So after people got vaccinated, I didn't see a whole lot of my ibrutinib patients going into hospital, which tells me that even though I couldn't measure the Bob immunity, there was probably some Tom immunity happening, and so those patients did have some level of protection, which is why it's important to still get vaccinated. On to alternative therapies. People always want to know, is there any benefit to things like cold effects? It's an immune boosting thing. So there was actually a clinical trial that found no evidence for reduced frequency of infections or respiratory illness by taking cold effects. There's been no randomized trials into vitamin C, and there is one population-based clinical study in Britain where they asked a pile of people to do a saline-based nasal spray if they got COVID, and they found that if they did that more frequently when they had COVID symptoms, they were able to reduce the duration of illness by a couple of days. So I want to shift now and talk about B cells in cancer. So that we know that B cells play a role in cancer in a good way in terms of all the little green dots is that when they do tissue samples, and if they find a whole lot of B cells in there, we find that patients actually do better when there's a whole lot of B cells in there. We don't understand the exact mechanism of it, but the more B cells found in and around a malignancy, the better the outcomes. So if I have less B cells, does that mean that this is going to be worse? And so this is sort of tied to why we're having that increased risk for secondary cancers, because those B cells are not able to respond and help the whole body to fight off these abnormal cells. So this is a Netherlands study looking at almost 25,000 CLL patients. Some of them were on drugs like ibrutinib, some of them had been on venetoclax, and they did find higher risks of skin cancer, lung, colon, prostate, lymphoma, a little bit of leukemia, and thyroid cancer. How high is the risk? The line down the center, males, line down the center, females. If something's on the line, that means it's not that big of a risk. The further it is away from the line, the higher the risk. So you can see the bigger dots are squamous skin cancer. So, basically those things that you're getting on your nose, those things that aren't healing, that are constantly scabbing over and then peeling off. And then there's the other risks around lung, etc. But the overall risks seem to be about 2 times higher than the general population. I'll just flip and say, when do these cancers get diagnosed? So the guys in purple were all before they even knew they had CLL. And then there's all the orange guys that were diagnosed after. And then there's the green guys that are all about diagnosed after therapy. So we know that there's, this risk is never going to go away, even if you've had your CLL treated. We do know that the risk is less now that we're not using chemotherapy with that FCR and FR that were talked about earlier. When we looked at monoclonal antibodies, the CD20 earring, the risks was there. When we add CD20 to fludarabine and cyclophosphamide, the risk was there. But there's a little less risk when you only got targeted oral agents. So we know that that is a good thing. And the risk around things like acute myeloid leukemia, which is a harder cancer to treat, has gone down with the no longer prescribing that FCR. In this population study, none of the patients treated with a novel agent had developed acute leukemia. So what should we be doing in terms of, if that's the risk, how do I need to advocate with my health provider around screening? So all of these are taken, recommendations are taken from the Canadian cancer screening guidelines. And so the first thing around skin cancer, so outside on the registration table, when you hand in your lanyard. So the black part of your necklace is recyclable, and there's a little bag there to hand it in. I've laid out a pile of these Melanoma Canada cards, so you guys can take one. And it talks about asymmetry, so things don't look the same. If it's not a mirror, if I was to fold it in half, it doesn't look the same on both sides. The borders are irregular, the color is varied, and it's more than 6 millimeters. And there's a little punched out hole on the card, so you can literally hold it up to your mole and see how big it is. Is it evolving over time? Did it look this way one week, this way the next week? And so there's actually some things you can do about in terms of tracking that. First, I would like to encourage you to go to Melanoma Canada to find a dermatologist near you so that you can actually have yourself screened by a professional. But if you're not fortunate enough to have somebody who's close, on the Melanoma Canada site, there's also Mole Mobile. So this is literally a truck with a trailer that comes around all across Canada yearly starting in May. It's free skin checks. All you have to show is your driver's license. You don't have, unfortunately, there's not an appointment. It's a first come, first served basis, but on the website, it will tell you when they're going to be and where they're going to be all across Canada. There's also this cool app that you can download that's called Compare Skin. And so you can take a picture of yourself and your moles you're concerned about, and then 6 months later, take one and literally overlap them to see if things are growing, which is kind of cool. When it comes to colorectal screening, I want you to, we talked about this again earlier in the conference about prevention in terms of no alcohol. So there is a definite risk for alcohol and cancer. And then, of course, having a healthy diet, but you should be having what's called FIT testing, which is a stool test, looking for blood in the stool. After the age of 40, you should consider it, and for sure you should be doing it between the ages of 50 and 74 every 2 years, if not annually. If you've had a colonoscopy, they will recommend when you next need to do your FIT test. If you've had previous polyps or if you have family history of colon cancer, then these guidelines may be not just for stool testing, but actually for having a colonoscopy. When it comes to lung cancer, number 1, don't smoke. But number 2, calculate your number of packs per day and multiply it by the number of years you smoked. So let's say I smoked for 25 years, but I was only half a pack a day. So then I'm about, 12 and a half, that's my number. So that's okay, but if I was 30 years smoking a pack a day, so if that number is greater than 30 and I'm still smoking, or I quit less than 15 years ago, then a low dose CT scan is actually recommended up to 3 times. And so on the graph on the left, it shows you that if you took 1,000 persons, those people in pink will have diagnosed lung cancer out of thousands of persons screened who had a smoking history of what we call 30 pack years, and 3 lives will be saved. Prostate cancer screening is a little bit more of a tough nut because the guidelines actually recommend that they're not to be screened, and that's because too many men end up getting biopsies and then having complications, and the biopsies were negative. And so they say that basically the harm doesn't give you enough benefit. And so this is something that you'll need to discuss with your family provider, making sure you're having an exam, also talking about if you're having any symptoms of enlarged prostate, and then potentially, discussing how often he might want to or feel comfortable doing prostate cancer screening, knowing that you have that increased risk if you're a male. With breast cancer, screening isn't recommended under the age of 50, but between 50 and 74, a mammogram every 2 to 3 years. MRI and CT and ultrasound are not necessarily routinely recommended, but if you have dense breasts, that might be something that is considered. And again, if you have an additional family history, then this should actually be even more frequent. Pap smears for women as well, every 3 years between certain ages, and then ovarian testing, there isn't any recommendations for ultrasound or blood testing at this time. So with all this talk of infection, vaccination, and cancer, CLL, and its treatment, I want to acknowledge that there can be a great deal of anxiety. So all of these things can be pushing at you, especially when you're very first diagnosed, and distress is a real thing. Emotional distress experienced by newly diagnosed patients is not a transient phenomena that gets better with time. So when we look at patients even 3 years out, those scores on a quality of life survey are flat. Everybody's still having a little bit of distress about their CLL. And some people are thinking about their CLL every single day. So in the first 6 months, 80%, but 2 years out, still half of patients are thinking about their CLL every single day. And I often ask my patients in clinic, how often do you think about your CLL? And I'm always surprised. There's some people who never think about it until I'm coming to see you, they say. And then their anxiety starts to ramp up just before their visit. But there's other people who are still thinking about it quite a lot, and especially in that first newly diagnosed, and especially if they're atypical diagnosed and they're younger. Offering more frequent monitoring has been suggested as a way to help with anxiety, and so I actually usually ask my younger patients how often they would like to be seen, and how often would they like to have their blood work checked. Because for some people, having it checked more often is going to cause more anxiety, and for some people, checking it less is going to be the better way to go. So I'll leave it up to them. There are some patients who will be advocating that they want earlier treatment, and that their belief is that by treating their CLL, their anxiety will get better. But in a survey of 105 patients divided into active treatment and watch and wait, there was actually no difference in anxiety, because all that happens is after the treatment, you start worrying about it coming back. So I really try to push against, until we meet the criteria, we're not going ahead with treatment. There's a reason for it. Your anxiety is not going to get better, but it's also, I don't want to use up all my cards treating the CLL until I have to. So there's a great survey that looked at unmet needs in CLL. So this was looking at patients who were having anxiety and depression during this time that they had CLL, especially when they weren't on treatment in that first part. And so in their top unmet needs, I was asking myself, where can I help? Well, being informed about things you can do to help yourself to get well. So we've talked about some of that today. Having a member of the hospital staff who you can talk to about all aspects of your condition, treatment, and follow-up. And we've talked about having a good relationship with your oncology or hematology provider. Having access to counseling. So most every cancer center will have access to psychological support. And if you're under the age of 40, they may have special counselors just for the younger population. Being informed about your test results as soon as possible. There was discussion earlier during the patient advocacy groups about having access to your electronic chart. And if not having access to your electronic chart, asking your provider for a printout of your labs when you see them. Being informed about the cancer which is under control. So when you're seeing, wanting an update of exactly where I'm at. And then being treated as a person and not just another case. So having that relationship where you're actually sharing, I'm a new grandma, or I'm looking forward to retirement. And so that your provider actually knows a little bit about who you are, and hopefully they're asking you those kinds of questions too. Dr. Banerjee talked about how she likes to know about how all her patients and the journey that they're on, because perhaps they've had a significant stressor in their life and that's contributing to their fatigue, etc. And so those are things that your provider does want to know. So as I mentioned, sign up to your electronic chart. Please come prepared to your appointment. I love it when somebody shows up with a journal. And I especially love it when they open up their journal and they have a list of questions written out for me. Because I'll say, fabulous, I see you've got your journal and some questions. First, tell me what's new and exciting. Tell me what's going on with your symptoms. Let's do your physical exam. Let's look at your labs. I'm going to talk to you about what I think we need to do. Did I answer your questions, or are there still more on your notebook? And then we go through each one of the questions until they're done. The appointment isn't over until the questions are answered. And so coming with those questions helps you, because rather than, there was something I wanted to ask you, I can't remember, because you're not going to get access to your provider again for who knows how long. And so take advantage of that undivided attention that they have on you at that time. When you're doing your journaling, please document concretely your symptom and its duration. I want to know how many times a week you're having night sweats, and I want to know, is it soaking the bed or are you just a little damp in the chest? Are you napping? How frequently? How many times a week? How long? If you're having infections, I want to know how many times did you need antibiotics? Did you need multiple antibiotics? And how long did those infections last? Have you had weight loss? And we're going to weigh you in clinic to follow up on that. And then if you're on treatment with something like ibrutinib or calibrutinib or zanubrutinib, we're going to be wanting to watch your blood pressure, racing heart, dizzy spells, any of those kinds of things we want to know about. So my last sort of take-home message, and the sort of way we're ending this conference, is I'm hoping that we can help you to reframe where you're at in your CLL journey. Every one of you I consider to be on a therapy plan. And so whether you're on watch and wait, or as Dr. Angelina Jerry said, watch and worry, or whether you call it routine surveillance, whether you're on treatment and still monitoring things, or whether you're between treatments, I like to take that W and W of watch and worry and flip them upside down and call it M&M therapy. So all of you are on M&M therapy, which to me stands for monitor and move on. It's our job to monitor together labs, symptoms, and physical findings. It's our job together to monitor the science if you want to, but do not feel obligated. We, as your care providers, know that that's our job. That's what we went to school for. I don't expect you to come as an expert. I expect you to join with me when we have to make treatment decisions and look at the science together and come up with a decision together, but I don't expect you to be an expert in it. And then in the meantime, in between appointments, we're moving on, not letting this diagnosis derail us from our retirement plans, our vacation plans, our special occasions. And if you find yourself thinking about your CLL all the time, have a pack of M&Ms and review your labs, review your notes from your last appointment, journal some so that you can talk about it with your provider when you see them again. So I want to just say thank you again. I love doing this. I am especially I have a geeked out science crush on Malcolm Gladwell. And he says it's not how much money we make that ultimately makes us happy between 9 and 5. It's whether our work fulfills us and being a teacher is meaningful. So I want to thank you for giving me meaning today.
So I think you'll all agree that was an amazing talk and an overview, and what a wonderful way to bring our last session to a close. I do want to give an opportunity for 1 or 2 questions, if there are any, though. So if there's a mic runner around, yeah, it looks like we've got a few hands, actually. Okay, we won't shortchange this. It's really important. So I can't actually. Okay, we got one in the back corner there. Here.
Why is the reason you don't have people over 75 do the FIT test?
Oh, it's actually just the test was only validated in patients up to the age of 75. And so we actually don't know whether or not it works after the age of 75. Presumably it does, but most funding places will only run the test if you're under 75. Oh, over here.
Yeah.
Over here.
We have
Sorry, hang on.
Hand in front.
Here we go. There's a question. You got that.
At a high level, in terms of antibiotics, how often do you do cultures to determine the right antibiotic? And again, at a very high level, I know there's like mild antibiotics, like in the US there's Augmentin, which is a combo, and there's also Super Duty, Avelox. And at a high level, what should a CLL patient look
So you have
out
to think like a family doctor. So and as a family doctor, you know, you're going to be aware of what's the germs that are out there in the community, what's the most common cause of pneumonia, and is it something that's going to be able to be looked after by a flat-out antibiotic like doxycycline that we can go ahead and prescribe, and then if it comes back a second time, we need one of those big things like Augmentin. But so your family provider is going to be following guidelines around what are the germs out there and how susceptible are they in your community. Because everybody's going to have different levels of resistance to different antibiotics depending upon where you live and depending upon how many times you've been in hospital, because you can pick up more resistant bugs if you've been in hospital, etc. So when it comes to cultures, I personally am only culturing if I've failed 2 antibiotics. Then I'm looking at, do I need to culture or do I need even more advanced testing? Sound reasonable?
It's a very hard question to answer generally, I would say. You know, but I think maybe where there's sometimes a bit of tension is dependent upon where you are in your journey with CLL and your degree of immune compromise and your pattern of infections and so forth. I would say, you know, on the one hand, there is still you know, you want to be cautious about over-treating things that may not be bacterial infections and trying to minimize antibiotic exposure, antibiotic resistance, but at the same time recognizing that, you know, in some cases it may be a bit of a unique scenario where you do have to be a bit more proactive in investigating certain situations which may be at higher risk. So I think, you know, it is, you know, it's a challenge that really needs to be, you know, again, kind of good communication between the primary care provider and the CLL specialist or whoever's managing that to make sure that in certain situations you are getting the investigations and care that you need, and in other situations it may be perfectly reasonable not to prescribe an antibiotic and to be managed through your primary care provider. So it's a bit tricky to answer that very broadly, I would say. Yeah. So
the other thing to consider is also remembering, depending on what season it is, if you show up to clinic in flu season and you have flu-like symptoms, you're getting a nose swab. Right?
We'll take one more, I think. Sorry, I know we're about almost 20 minutes over, I think. So we'll take.
Yep. Some time ago, I came across an article by Dr. Bird, well-known CLL specialist, who suggested that for the elderly, Shingrix is not very effective. Do you have any comments?
I would probably defer to Dr. Bird, but at the same time, because he's amazing, but I would wonder if, was he speaking specifically to the CLL patient?
Maybe I'll answer that a little bit more broadly.
I can't tell you.
Yeah, it's okay, yeah. You know, in very broad terms, I think again, I'm not sure exactly the article or the paper that you're referring to. You know, we would still recommend Shingrix as an option for patients in an immunocompromised, you know, potentially immunocompromised state. Shingrix or shingles, I mean, although it's not a life-threatening infection typically, it's a quality of life, you know, threatening complication. It's the postherpetic neuralgia, which can be so devastating. And so, you know, vaccination in general, there may not be the same degree of immunity as somebody who's not immunocompromised, but it's very difficult, you know, kind of a priori to know exactly what degree of benefit one individual may gain from it. So if there's not really a concern about harm and you're at risk, then it's very reasonable to try and gain the potential benefit from vaccination, and which is why it shows up on all of those lists. So it's not that Dr. Bird is wrong. It may not be as effective as it may be in somebody without CLL, but it doesn't mean that it may not provide somebody with CLL some benefit, and in some patients, perhaps full benefit. So you need to be aware of that, and this is true of probably of any vaccination. You do need to be aware of the fact that, you know, that there may not be perfect protection, and you still need to monitor symptoms and bring symptoms to the attention of, you know, your doctor. So for example, the shingles, if you've had the vaccine, but you end up with the painful rash, you know, not to think, well, I've had the vaccine, it can't be shingles. Yeah, again, I think that maybe is a bit more of a general concern as opposed to a specific concern. There are changes in our immune systems that are also, to some degree, age-related. There's changes to the risk of infection depending upon additional comorbidities and additional, kind of concerns like immunocompromised state. So again, I would kind of view that more as a bit of a general comment. I mean, I'm not saying that that is wrong to say that there may be less effectiveness, but I'm not sure that I would take that to imply that, that vaccination shouldn't be offered or considered, but to be aware of some of the efficacy concerns, perhaps, that, people like that article are kind of referencing. Does that make sense? Yeah.
So just on the last note, remember the Melanoma Canada cards are beside the registration desk when you hand in your lanyard. That's it.
So please, that was a fantastic talk, a great practical overview. And